Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. Hello and welcome back to the Ophthalmic Referrals series. Today we're going to talk about medical retina referrals. I would encourage you to watch the first video in this series, which covers the generic information which we should include in any ophthalmology referral, because that will underpin this talk and all the other talks in this series. Please remember that this is how I would process a referral for medical retina patient, and you must use your own professional judgment and follow any national and local guidance that's in effect. Medical retina is a very broad subject, so it includes any disease of the choroid, the retina and the macula. For example, a pigmented fundus lesion, macular degeneration, retinal vascular disease such as a retinal vein occlusion. And you'll see at the bottom there's a reference to the recent guidance from the Royal College of Ophthalmologists about retinal vein occlusions. Remember that diabetic medical retina is often separate to other medical retina. The medical retina team don't appreciate being sent glaucomatous disc hemorrhages, so please reserve those for the glaucoma clinic. And when they treat patients, they tend to use drops, injections and lasers. And we should differentiate that from the vitreoretinal team, who are surgeons. And they're interested in the vitreoretinal interface, so more anterior retina, as well as retinal degenerations and tears and detachments. I'd just like to touch briefly on a few resources, so starting with the NICE NG82. They give us a number of classifications which move us away from the old idea of dry AMD and wet AMD. They also provide some referral guidance, so pertinently for the late wet active AMD, we should be referring within 1 working day and the patient should be offered treatment within 14 days of that referral. They talk about the need to have clear pathways between primary and secondary care, and you should also be aware of your local guidelines, because sometimes certain levels of visual acuity may not be suitable for that wet AMD pathway. Pigmented fundus lesions also fall under the remit of medical retina. The College of Optometrists have reasonably recently produced a clinical management guideline on pigmented fundus lesions, which is definitely recommended if you haven't had a look at it so far. They talk about the importance of baseline and sequential colour fundus photography. They also talk about the benefit of OCT and autofluorescence to help to differentiate a potential choroidal melanoma from a choroidal nevus. And they also introduced the moles scoring system, which, if you haven't seen that already, it really is helpful to familiarise yourself with that. It will help you to differentiate between a low and a high risk lesion. Let's start off with the basics. We want to know if the patient has presented with symptoms or not. If they have, we want to know about the onset and the duration. And we want to know if any distortion or metamorphopsia has been spontaneously reported by the patient, as in they volunteered that information, or has that only come to light when we've shown them an Amsler grid? You'll probably find that appears on any local fast-track wet AMD forms that you have, those specific terms. If the VA is down, we want to include the previous VA if we have access to it, so we can see how much change there's been there. And a basic description of the lesion. We're not expected to be medical retina consultants, we're not expected to diagnose everything that we see, but we can all have a go at describing a lesion. Is it hyper or hypopigmented? Does it seem clearly raised or is it flat? And can you see any hemorrhage there? This information is extremely helpful. And imaging really is the keystone of any OMR referral. Clear fundus photos and relevant OCT scans tells the recipient a huge amount about that patient's eyes, and it will help them to triage that patient with an appropriate time frame. What should we try to avoid on our OMR referrals? Well, simply stating AMD isn't really going to help to differentiate between the early dry type of AMD and the late wet active AMD. So it's not descriptive enough. And there's a whole host of other vague terms such as macular changes, macular lesion, maculopathy. And we really just need to make a little more effort to try to describe what that particular change or lesion looks like. Once we've got the basics right, we may then choose to upgrade our referrals. And I've just chosen two areas that we may wish to focus on here, so vascular and pigmented fundus lesions. But as I said, OMR is a big subject, and these are just two examples. So from a vascular perspective, a lot of it really is around the history, the personal ocular history, the personal medical history and medication, so anything that can affect the vascular system in particular, their social history, smoking, heavy alcohol use, stress, BMI and diet, as well as any relevant family ocular history. In terms of pigmented fundus lesions, again from a history perspective, we're looking more at things that point towards malignancy, so a lot of UV exposure, recent weight loss, recent fatigue, a family history of malignancy, any floaters or photopsy associated with the lesion. Previous lesion imaging is extremely valuable because it can help us to see if there's been any change. And the lesion description here can be a little more detailed, so colour, size, shape, position, surface features, that's going to be drusen for a more chronic lesion, or lipofuscin for a more suspicious lesion, and of course elevation. And that information will help you to assign a mole score to the lesion, and then it will help you in turn to know how quickly to refer, if at all. Is it a 2-week wait, suspected malignant melanoma referral, or is it a patient who can be monitored in practice if you have the appropriate imaging equipment? So if you've made the referral to ophthalmology and you think it'll be a number of weeks or months before they're seen, and you're concerned that your patient may have an underlying undiagnosed systemic condition, then it may well be sensible to make a separate referral in the interim to the GP so that they can investigate, diagnose and start to manage that condition, hypertension, diabetes, whatever it might be. If you are going to do that, try and make it as easy as possible for the GP. So include your tentative diagnosis and even give them an indication of the types of tests that they may wish to consider doing. For example, with a vein occlusion, you might be thinking about blood pressure and certain blood tests. We're not expected to be medics, but what we do want to do is get the GP on board. So try to avoid saying, please perform a full systemic workup, which may well be too broad for the GP to take seriously. Thank you for joining us for this talk on medical retina referrals. Next time we'll talk about oculoplastics referrals. Thank you.